All right, we are going to get started with Telehealth on Trial Case 2. So we're going outside of the courtroom and into a medical boardroom. And I will punt it to this esteemed panel.
All right, good afternoon, everyone. I'm going to start by making the very original joke that we are the panel standing between you and lunch. So we will try to remain on time and get you there as soon as possible. So our telehealth on trial is a bit different. It's in a different legal venue. It's in front of the Board of Medicine, State Board of Medicine. Most states, and all states, have a State Board of Medicine, as they do for boards for just about any licensed profession. Their laws are similar, but can be different. So if you know your state, you know your state. You know your personalities on the board. Today we are going to have, we're generally set up here, and you'll see that you are going to be playing a role as the board. You're going to be collaborating with our board chairman, who's played by Dr. Neil Reynolds. And we're going to be presenting you with some allegations against one of the licensed physicians. You would think that disclaimers were prepared by the two attorneys on your panel, but actually these disclaimers today were prepared by our clinicians. So to start, we are actors. While two of us are attorneys, we are actors as far as being board attorneys. We're actors are everyday Joes and Josephines, so please cut us a break. Some of the characters may be imperfect because we are. One of our actors is actually an unbelievably busy and good telehealth, telemedicine provider, and she does not like to be portraying the losers. This is a stretch for her, so cut her a break. And this is fictitious, of course. If it's any at all similar to real life scenarios you've seen, it's all made up and coincidental. So there. Okay, our roles. Dr. Neil Reynolds will be our chairman of the Board of Physicians. Dr. Pampas. Mr. Gorka will be our board investigator, played by John Cornack. I somehow got the title of Counselor Smartsky, so thank you, Neil. I'll be playing that role on behalf of the board. Dr. Amareldum is played by Carrie Pelicanis, our renowned telehealth provider. And Counselor Luzamal is an attorney for the physician. Sorry, Joe. And you will be the board. So unlike a court where there's going to be a punitive process, penalties come down. I mean, there will be penalties potentially in front of a board, but the decision for the board to deliberate is whether or not, yes, the standards of care were met, but generally the board has to consider whether all of the factors presented constitute an unsafe environment for patients, for the citizens of the state in which the board regulates the profession of medicine. It's more of a collaborative. It's formal yet informal. So other factors are considered. And at the end of our presentation, we are going to present you with some questions, similar to the last one, about 5 or 6 questions. And we're going to prompt you with not only thinking about the liability or the actions of the physician, but also the other contributing factors. In addition to the differences of the forum, the angle of this is quite different. As you see, the issue in the last one was whether or not the failure to use telemedicine technology or telehealth capabilities in some way contributed. Well, you'll see here we are using telehealth capabilities, and you have to consider if and how perhaps that contributed to the bad outcome in this scenario. So it's a little bit of a switch. And we can begin.
I am Dr. Pampas, it says, and we're going to begin this board hearing. As the board chairman, I'd like to introduce the case to you. We've had a complaint brought against Dr. Amareldum, and this will be presented by a variety of folks up here. I'd like to introduce the Counselor Smartsky, for the Board of Medicine.
Thank you, Chairman.
Would you like to introduce your first witness?
Yes, thank you, Chairman. I'd like to introduce Dr. Gorka on behalf of the board. Good morning, Mr. Gorka.
Good morning.
To start, could you please give us a brief background of your experience in relation to matters like this?
Sure. I've been a board investigator for over 10 years. On behalf of the Board of Medicine, I investigate allegations against licensed physicians and objectively report my findings today.
Thank you, Mr. Gorka. Could you please, in relation to the allegations brought against Dr. Emreldum, could you please recite and describe your findings for the board?
Yes. A 10-year-old boy sent home by a school nurse on November 12, 2017. The mother, Betty McGee, brought her son, Robert McGee, immediately to the Quickie Pharmacy kiosk at the Super Mega Mall. Betty summoned the remote doctor, who appeared on the screen nearly immediately, Dr. Emreldum. The mother reported that Bobby had been feeling poorly for the past 2 to 3 days, aching muscles, sneezing, runny nose, and fever. The temperature was 39.4 degrees centigrade. Dr. Emreldum asked about a sore throat. Bobby thought he had a sore throat. Dr. Emreldum did a light assisted examination of the pharynx, thought the throat was inflamed, diagnosed bacterial pharyngitis, and prescribed an antibiotic of amoxicillin.
Thank you. Please continue.
Seeing that Bobby seemed a little short of breath, Dr. Emreldum recommends that they go to an emergency room for a chest x-ray. Betty declines that everything will be fine as long as he has his antibiotics. Betty quickly picks up the antibiotics right there at the Quickie Pharmacy. Bobby gets his first dose of amoxicillin almost immediately. The mother and son go home. Bobby takes Tylenol, drinks some Gatorade, and goes to bed at approximately 4 p.m.
Please continue. What happened next?
At around 8 p.m., Betty goes to Bobby's room to find the boy to be unarousable. Betty calls 911 for EMS, and an ambulance arrives within 7 minutes later. The paramedics cannot arouse Bobby, finds his pulse oximetry to be around 68% and his blood pressure to be 83/45. As oxygen mask is applied to deliver 100% oxygen, IV fluids are administered and the patient transported to the local 125-bed community hospital, arriving 22 minutes later. In the emergency room, the patient is immediately intubated, placed on life support, given 2 more liters of IV fluids, deep venous line placed, and medications given to improve the blood pressure.
Thank you. And continue. What was the outcome?
Bobby was found to have pneumonia and a swab positive for influenza A. Emergency doctors could not achieve adequate oxygenation and decided to transfer Bobby to the Regional Quaternary Medical Center. Bobby was transported within 72 minutes via helicopter to the University of Everything Medical Center for ECMO.
Continue.
Bobby was received at the University of Everything Medical Center, rapidly cannulated for ECMO.
And for those in the board, that is the please correct me if confirm if I'm correct, that is the insertion of large tubes to remove and return blood from the ECMO equipment.
Correct. Over the next 4 days, Bobby developed multiple organ failures, refractory to all modalities of life support, and unfortunately died 108 hours after being seen at the Quickie Mart kiosk. And those are my findings.
Thank you, Mr. Gorka.
Councilor Smartsky, do you have any more questions for Mr. Gorka?
I don't. Thank you, Chairman.
Thank you. Councilor Luzmal, do you have any questions for Mr. Gorka?
Thank you, Mr. Chairman. I do. Mr. Gorka, as I understand it from your report, the patient suffered from pneumonia, is that correct?
Correct.
Okay. Now, when you commenced your investigation, did you go to the Quickie Pharmacy?
No, I did not.
And did you do any inventory of the equipment that was available at the Quickie Pharmacy?
No, I did not.
Okay. Did you review the recording that was made of the patient interaction at the Quickie Pharmacy?
There was no recording.
Was no recording. Did you speak with the patient's mother?
Yes, I did.
And did the patient's mother confirm that there had been a request for the patient made by Dr. Imriel Dum to have an X-ray done?
Yes, I did.
Okay. And if that X-ray had been done, it may have revealed certain information that may have changed the outcome, correct?
Correct.
No further questions for this witness?
Counselor, would you like to call, excuse me, any other witnesses?
I would. I'd like to call Dr. Imriel Dum to the stand.
Dr. Imreldum, please take the podium.
Yes, thank you. It's Imreldum, not Imreldum.
I apologize. Doctor, what is your training?
Family practice.
Family practice. And discussing the specific facts of this case, did you take the patient's complete vital signs at the time of your examination?
No, at the Quickie Pharmacy, they just have a machine that measures blood pressure, and then we just observe for respiratory rate.
Okay. And did you, were you aware that the patient did not get Tamiflu?
I looked at the patient's medication list and inquired, but yeah, I was aware that they didn't.
Now, if you had given the patient Tamiflu, would the patient be alive today?
Not necessarily.
Not necessarily. Did you provide any sort of guidance with the patient when the patient left?
I asked the mother to take the patient for a chest X-ray.
Okay. To your knowledge, was that done?
No.
Let's see. Now, doctor, with regard to this patient, did you examine the patient's breathing?
I saw the patient breathing.
You saw that the patient was breathing?
Yes.
Okay. Why did you prescribe antibiotics for this patient?
Because when I looked at the throat in the telemedicine device, it was red and there was white patches on it, so it was consistent with bacterial pharyngitis.
And in your mind, did the patient exhibit any signs of influenza?
No.
Would it have been helpful if you had had a digital stethoscope on hand?
Well, yeah, always.
And so there wasn't one there. Did you speak to anybody about that?
No, I don't work there all the time. I was just covering a couple of random shifts, and I was surprised that they didn't have it. But
So you work at other pharmacies?
oh yeah, I work at like 28 different pharmacies.
28 different pharmacies, okay.
I'm trying to pay off my med school loans.
Do you generally complain when there aren't the needed equipment at the locations that you practice?
Well, I can complain, but no one listens. You know,
Okay.
they don't only care about money.
Don't we all? Now, why did you continue working at Quickie if they didn't have the necessary implements for you?
Because they pay really well.
Okay. Now, did you happen to check their regional health information exchange to see about this patient's prior medical history?
Yeah, I started to, but I don't know if you're familiar. The regional health exchange sucks. And I went on it, and first of all, it takes forever to get on it. And then when I got on it, there were like 12 other Bobby McGee's there, so it's not like I could have the time to really look it up. And I just didn't.
So it wasn't useful to you?
It never is.
Never is. Okay. Now, you requested the patient get this chest X-ray, correct?
Yes.
And was that just for a particular reason? Why were you asking for the chest x-ray?
Well, I was really covering my ass, but he kind of coughed a couple times during the visit. And since I didn't have stuff to really check it out, I figured get a chest x-ray.
And if you had seen the chest x-ray, it would have shown that the patient had pneumonia, wouldn't it?
Possibly, yes.
Okay. So if the patient had followed your advice and gotten the chest x-ray, you would have had other information at your disposal, is that right?
Definitely, yeah.
Definitely. No further questions this time.
Counselor Smartsky, do you have any questions for Dr. Imreldum?
I do, Chairman, thank you. Dr. Imreldum, you mentioned you're a family practice practitioner. Do you have any experience as a pediatric practitioner?
No, in family practice, we learn birth to death, so about 50% of my training's pediatric, but not specific pediatric.
Are you trained in infectious disease?
We briefly cover it in school.
Do you feel comfortable diagnosing or ruling out diagnoses of infectious disease based on your brief training?
No.
In medical school or residency, did you ever experience some exposure or training in telemedicine or telehealth generally?
No, they were at University Knows It All. They said that nobody actually does telehealth. So, and yeah, I was just trying to get through school.
So you wouldn't, or would you, or what is your assertion, would you know whether or not telehealth equipment was lacking or not up to par as it should be?
Well, I've been in some places where they have more and some where they have less, but I was just told telehealth is always inferior.
How many hours had you worked on the day in question?
That was about my 18th hour.
And in taking the history of Bobby McGee, did you learn of any other exposures to others with flu or the flu-like symptoms?
No, I forgot to ask.
You didn't ask. No. Did you ask about underlying illnesses?
Not really. It was like every child in town had the sniffles that week, and there was just hundreds of people that I was seeing with the same thing.
Was it also perhaps because you were too busy or even sleep deprived?
Well, I don't feel like I get sleep deprived, but yeah, I was definitely busy.
Did you know this child had asthma and recurrent bronchitis and was therefore more susceptible to lung infections?
No, the mother didn't disclose that.
Were you aware that the parents of this patient are against routine vaccinations such as that influenza?
No, I didn't know that.
Did you ask?
No.
Did you take complete vital signs for Bobby McGee that included his blood pressure?
No, well, yes, I did take blood pressure and I did have the temperature, but I was limited beyond that because that's all that was available there.
Did you notice anything unusual about his breathing?
Well, he kind of had his arms under and he was shaking and he was cold, so I thought he might be breathing a little fast, but it was hard to tell because he was shivering.
And you did not measure the blood pressure?
No, we didn't measure the blood pressure. I think the machine wasn't working that day.
Okay. Did you measure the pulse rate?
No.
Did you listen to the patient's lungs with a digital stethoscope?
There was no digital stethoscope available.
And did you ever ask about being equipped with a digital stethoscope from Quickie Pharmacy?
No, it was my first time working there, so no, I didn't.
Nail bed, did you look at a common indication of issues like this under patients' nail beds, is my understanding? Did you examine the patient's nail beds?
No. I mean, it's rarely useful in children. Plus, like I said, he kind of had his arms like this, and he was shaking, so I couldn't really see them.
You say it's rarely useful, but to be clear, did you look at them?
No, I did not.
Did you measure his pulse oximetry? To get an estimate of the blood oxygen level?
They didn't have a pulse ox available.
Quickie did not.
No.
Did you instruct the mother on what to do if the patient became short of breath?
Yes, and I also instructed her to get a chest x-ray.
Did you know how practical that was for the family and how close they may live to an acute care facility?
No.
Was there any sort of assistant or presenter at the telehealth site who could perform some sort of examination at your direction?
Not that I'm aware of. I think it's just like a kiosk they walk into and put their arms in things.
Would you have done something differently if you had known that the pulse oximeter was 80% on room air?
I would have asked that the mother take the child to the emergency room, but since she didn't take him to the chest x-ray, she probably wouldn't have done that either.
And had you been able to listen to their lungs, would you have done something different if you had heard unusual sounds coming from their lungs, such as rails, or discovered evidence of pneumonia?
Again, I would have asked that they go to the ER and do what I already told her to do, which is go get a chest x-ray.
And again, same question, if you actually had the data to know that his blood pressure was low.
Well, blood pressure in kids is not a real standard thing that we check, and, I don't know that I would even find it that useful.
Would you have done something differently if you had seen a chest x-ray and not had a chest x-ray at that moment?
Well, sure, yeah.
But you'd never suggest, I withdraw that question. Were you aware that this patient came right to you at the peak were you aware of what was going on in the community with respect to influenza?
Yeah, everybody watches the news.
And did you take that into consideration when examining Bobby McGee?
Yeah, sure.
So you did it. You did or you did not? Yes or no, be more helpful for the board, please.
No.
And were you aware that there have been 7 deaths in pediatric patients on the East Coast this year?
I knew there were deaths. I didn't count numbers.
Interesting. Thank you. Thank you.
Mr. Chair, I'd like to ask some further questions.
Councilor Luzmal, you have the podium.
Now, you were doing this through telemedicine, so you were, as I understand it, approximately, 1,000 miles away from the patient?
Yes, that's correct.
So you wouldn't necessarily know all the details of what was going on in the community, would you?
I don't even know where it is.
You don't know what?
I don't even know where it is.
You don't know where the community is?
Somewhere in
Okay.
that
Just-
part of the state.
They were in a pharmacy?
Yeah.
Right. And you also practice in person with patients, or is it only telemedicine?
No, I have a family practice also.
And do you find that in person that parents often ignore your advice?
Yes, frequently.
Do most people ignore your advice?
I hope not, but yeah, parents do what they want to do.
Do what they want to do. So do you think that if the parents ignore your advice that you should be responsible for the outcome of this patient?
Don't get me started. Because the insurance companies think I should be, and I think that it's not fair that I'm accountable for everything, but the parents aren't accountable for anything.
So basically it's the parents' fault.
Well, yeah, they didn't follow my advice.
Okay. No further questions.
Thank you. Dr. Emeraldum, you may sit down.
Closing statements.
Are there any closing statements from Councilor Smartsky or Councilor Luzmal?
Chairman, I have a few closing statements. Thank you. Ladies and gentlemen of the board, you have heard various assertions, testimonies, facts, findings of a renowned investigator, Mr. Gorka, with the unfortunate death of Bobby McGee. The board would assert that all of the bad outcome here not only is caused by the failure of Dr. Emeraldum to meet the applicable standard of care, but here we have what could be viewed as an over-reliance on telehealth. And in the context of telehealth, we must ask ourselves, is there a heightened or a different standard of care that must be met? Must the technology provider, must be of a different stature, and is the physician responsible for that? In the context of communicating via telehealth, I would assert that there is a heightened and more sensitivity to communicating via telehealth when you have perhaps uneducated or less educated patients, and particularly pediatric patients who are being guided by their parents. Perhaps they are of certain mindsets, but the additional burden, unfortunately, on our licensed practitioners in the context of telehealth is to be heightenedly sensitive to these things. So it's not did she just fail to meet the standard of care for her practice as a licensed physician, but in the context of telehealth, does that add any additional burden that she failed to meet? The board would assert that the answer to that is yes, and the board should impose appropriate sanctions they feel due. Thank you.
Councilor Luzamo, final statements.
Thank you, Mr. Chairman, members of the board. You're being asked today to decide whether my client, Dr. Imril Dum, whether her conduct, not whether it was negligent, but whether it was unprofessional, whether she should be practicing in your community or not, whether she was reasonable in her approach with regard to this patient. And I would suggest that if this patient had actually followed her advice, meaning gotten a chest x-ray, the outcome would have been significantly different. Now, she may not have had all of the equipment that was necessary, but should she be penalized for that? That's a question I think you need to consider. Ultimately, I think that if you consider the facts in this case and you consider whether or not the parent who played an important role in the outcome of this child's unfortunate demise, whether all of that taken into consideration resulted in this patient's death, I think that you would find that, in fact, my client acted in a professional and reasonable manner under the circumstances, and there may have been other factors that contributed to the unfortunate outcome in this case. And we would ask that you find for my client and not impose any sanctions. Thank you.
Thank you, Councilor Luzamo. Lose them all. Well, it's now time for the board to begin to deliberate, and you are the board, and I'm going to give you a sense of what you might be like and this comes from my experience with the Maryland State Medical Board. It's about 1/3 physicians who are very enthusiastic about telemedicine, about 1/3 lay people who don't know anything about it to speak of, and then there's about 1/3 of physicians who are really against it for various reasons. So we look forward to people having different opinions here, and that's part of the game. We're going to ask you to dissect this apart in many, many different ways. And we're going to be asking you questions, and we'll do it electronically in a moment. And the first question will be, should we sanction Dr. Imreldum? Say it quickly. At any rate, I want you to consider whether the physician failed to perform a good history. We heard that she didn't know about the lack of influenza vaccine. Did she do an adequate virtual examination? Did she obtain complete vital signs, or was there a failure to abide by standards of care? Did she look for signs of low blood oxygen, that being cyanosis of the nail beds? Did she get a pulse oximeter? And did she consider the current influenza epidemic? So we're going to ask you now to go to your app and vote up and down. Yes would be a vote that Dr. Imreldum should have a sanction. Please vote. Okay, so the board is voting, and I'd say overwhelmingly that she should be sanctioned. Thank you. Now we're going to look a little bit beyond that and dissect other elements of this. And even though the Quickie Pharmacy is not on trial here, is there contributory negligence from that pharmacy. And I want you to consider whether they failed to provide necessary equipment such as the electronic stethoscope or the pulse oximeter, failed to provide a surrogate examiner, or maybe in your thinking you're wondering, is that standard of care in these quickie clinics? Did they fail to limit the number of hours? You heard Dr. Imreldum had worked 18 hours and she might have been a little bit tired. And were there financial incentives? So we'll ask you to vote. A yes would be that Quickie Pharmacy is contributory to negligence in this bad outcome. Yes, overwhelmingly, even more so than the sanction on Dr. Imreldum. So is there contributory negligence in the world around us, the telehealth technology? For those of you who've tried to use some of the health information exchanges, you notice they can be rather frustrating. They're not quick, and maybe it's hard to get the information. So is telehealth technology a contributor to the bad outcome here, lack of information exchange? And a vote yes will be that the technology was a contributor. Please vote. Not so much, but actually no. Okay, interesting. I think this perhaps is a fairly relevant question in this particular case, but were the parents, again, they're not on trial, but in your thinking process, were they contributory by failure to provide certain bits of information? So they had made a decision because of their beliefs that their child should not have influenza vaccine. They didn't share that. They falsely believed that antibiotics are the solution to everything. We as physicians encounter this day in and day out. Did they actually send their son to school that morning when he was already too sick, and were they culpable at that point for not moving? Maybe even 6-8 hours would have made a difference. I'll ask you to vote yes, that the parents are contributory, or no, they are not. Wow. Oh my, I had not expected this. So the parents had a big role in this. Fascinating. This is kind of a relevant question. Is it just bad luck? Some people get bad diseases. Bad diseases can kill you. This child got a bad disease and he died. There was a lot of kids who died. I think, what was it, 137 or 173? I'm dyslexic. During this most recent time. And either way, even if they got the vaccine, it doesn't work all that well. And even if they'd gotten the antivirals, it doesn't work that well. So was it just bad luck? And I'm going to ask you to vote yes, it was just a bad disease, or no, that's relatively irrelevant. I think I know how this is going. Okay, it's about split. We're going to go ahead and enter into a panel discussion and allow some people to offer some opinions, and allow Dr. Imreldum now to actually be herself, Dr. Carrie Pelikanis, and I'm going to ask her to share some thoughts.
Well, for those of you who voted for me not to be sanctioned, thank you. I've made it 29 years and have yet to have to be in this scenario, so I'd like to keep it that way. Couple of things here. One of the things that when Neil first created this scenario, I was like, well, it's not actually realistic, Neil, because I do, as they mentioned earlier, do a lot of telehealth. I said it's not realistic because some of these things are going to essentially be in place. But from a disease standpoint, the case presented was that the child had already been sick for 2 to 3 days, which immediately takes them out of the realm of being able to be given Tamiflu to begin with. So it wouldn't have mattered whether he had flu or not. There's no actual treatment at that phase in the disease beyond what we treated the child with. So the standard of care as far as needing to give the child Tamiflu or do a flu test wouldn't have mattered anyway. So even the flu vaccine wouldn't have mattered. The blood pressure machine is usually something that's fairly standard in most of these quick mart places, but I, like I did want to throw in that it wasn't working because that does happen a lot. And so the idea of having to have a backup or a fail-safe mechanism as far as a participating person in the arena is very important. And I think it's something that if any of you are looking at starting telehealth systems, especially in remote areas, that you better have fail-safes on your internet service provider as well as in your equipment. Everybody's worried about cost and trying to keep costs down, but you need to always plan for the what-ifs aren't there. And ironically, when Neil wrote this, it was about the time I actually had a similar case, but a in-person case. I do a hybrid practice. I have standard family practice as well as do quite a bit of telehealth. And I had a young 6-year-old boy come in, came in with flu symptoms in my office. I do have flu tests, and I did flu test him. His mom did not get immunizations because I'm in rural Maryland and they don't do immunizations there. And then on top of it, this year, being flu season, many of the parents would say to me, well, I already heard that the flu shot's not effective anyway, so why am I going to hurt my child? And, so this was an exceptionally difficult year for managing flu. And even people who did get the flu shot were getting the flu, and I saw that in practice too. But I did have a 6-year-old boy come in. I did flu test him. He did turn out to be flu A positive. He was within the Tamiflu range. He was within the first 2 days. I ordered Tamiflu for him, sent him on his way, ignorantly believing, like I oftentimes like to delude myself, that people actually do what I tell them. But I saw the child a week later, and the mom had been to the emergency room. He'd had pneumonia. He didn't die, thank God. But she came back in for a follow-up from the emergency room, and she said, I guess I should have given him that Tamiflu you ordered, huh? And I was like, what? And she said, yeah, I got home and I read the label, and yeah, I didn't want to give that to him, so I didn't give it to him. So the boy progressed into pneumonia anyway. Whether or not that Tamiflu would have been helpful, hard to say. But even with all of the bells and whistles and everything that I would have had in private practice, in real-time practice, same kind of outcomes occur. So sometimes it's very easy to jump to argue that the telehealth is the reason for the outcome. Certainly, telehealth is just a tool in the greater picture of what we do. But then my personal experience in telehealth is to remind you that don't rely on what you put out in the field 100%, because you are going to have things like failure in internet. This morning, had an internet failure at my office during a telehealth visit. We have actually 2 other backup lines for internet because we do so much telehealth. And then I have equipment fail all the time out in the field, so I standardly now have a backup resource equipment everywhere. Plus, I like to make sure that I always have an examining assistant in all of my telehealth outlying areas. So that's
Thanks, Carrie. Well, I'm glad that at least some of you thought the parents were responsible. At least I got that point across. And I would say that if this were a true Board of Medicine hearing, one of the things that I would do, which we didn't have time for, is we would have an expert testifying on behalf of the physician. But putting that aside, I think some of the points that that this scenario explains is one is that that the follow-up is important, and sometimes in telehealth it's not as easy to have follow-up as it may be in real time, but if there's a way to build that in, that's certainly important, because if they had made sure they got the x-ray, they would have noticed the issue of the pneumonia coming on. The other thing I wanted to mention is that this physician was located 1,000 miles away from the patient, which is not unusual, obviously. But one thing, if you are involved with telehealth, to keep in mind is that every state has its own board of medicine, board of physicians, and in many cases, at least in Virginia where I'm from, they put out guidance documents on telehealth, and those guidance documents can in some ways dictate the standard of care to some degree. So it's important to be familiar with those guidance documents. So you want to check that if you're going to be practicing telehealth in a particular remote state.
So in typical fashion, I'm going to pull up a few PowerPoints. I did a little bit of due diligence here, and I found some fascinating information. The slide in front of you has Volume 1, Issue 2 of the Telemedicine and eHealth. And bear in mind, that's the second time they ever published that in 1995. And the fascinating thing is they jumped right into legal issues. So they weren't, people started thinking about this immediately. So part of the questions are, what is standard of care? It's fairly easy to get people to agree on what the standard of care is for vital signs. And of just about every source I went to said you got 4 vital signs. Yes, there's people who say there's a 5th one called pain, and some people talk about body mass index as a vital sign, but almost none of them mention saturation. You'll notice on the very bottom, an emergency medicine organization says, yeah, get SpO2 if you can. So that's not a standard of care in general. However, when you begin to evolve and think pulmonary disease, well, that's a different issue. But in terms of basic vital signs, it doesn't seem, well, you need to get all 4. The question whether the lungs should be auscultated depends on which way you're coming from. If you've made the diagnosis that it's an upper respiratory infection before you've taken a history and physical and whatever, then you don't need to test the lungs or examine the lungs because it's upper. But the fact is that when you meet the patient, you don't know what they have. So if it's an upper respiratory infection, you can get people to say, well, maybe you should, or maybe you should. But if it's a lower respiratory infection, you have to examine the lungs. And at time 0, you don't know. So I'm going to say that the standard of care for not listening to the lungs was indeed violated in this case. Poor communication. This data, as John without an H pointed out, is an interesting article because it comes from Canada, but they talk about American hospitals. And it is talking about hospitals, but generically it's talking about poor communication. 44 to 98, almost 100,000 deaths ascribed to just poor communication. And in this case, there were some elements that the family withheld. So I would say that's poor communication. I tried to find a source, an authority to tell us what is the parent's obligation to share information about their children. And the Children's Hospital of Atlanta, which is a very solid organization, I believe, suggests that in fact it is the parent's obligation to provide accurate, complete information about present and past illnesses, et cetera, et cetera. So in this case, and you all reflected that in your 90% condemnation of the mother, that there was a major failure from her and she should have come up with some important information. I'm going to go back one step here, or not. The CDC has a website that is very close to real time, and it's updated every month, and it's one of these maps of the United States of America, and it's divided into states, and it's given of Maryland. At any rate, it's divided, colored according to the severity of the flu. At that time in the year, the whole continental U.S. was bright red, in other words, very severely involved with the influenza. And if you care, through all the 12 months, Alaska was always red, and Hawaii was always a good color. So there. So at any rate, the message there is the information was readily and easily available. I'm going to hand the mic over to Counselor Smartsky.
Only time I'll probably be called that. So it may have been painfully obvious to those who do board hearings that I am not an attorney that represents physicians at the boards. I think I have represented 1 or 2 social workers, and when I started law 15 or so years ago. I do a lot of regulatory work for telehealth providers and other healthcare providers, so I was a little bit out of my comfort level. But I think even in representing and helping our clients decipher the myriad of regulations, including licensure, it does come back time and time again with the standard of care. as other attorneys in the audience can attest to, various states are very active now in trying to get their regulations up to date. And sometimes they're consistent among the states so that you can advise clients consistently. Sometimes they're very different. Bottom line is you have to look at every state's code and the guidance documents that John mentioned. And those regulations, guidance documents do help to outline what the applicable standard of care is going to be. However, I will say my personal opinion is that when they are less prescriptive, it's actually better for the board and for practitioners, because then they can then exercise their professional discretion and judgment and have more of an academic clinical debate, whether it's at the board or otherwise, as to whether the standard of care was met, because it is going to change as these capabilities and the service lines change. And as we all have seen, us lawyers, regulations don't keep up with the change. They don't keep up with what's actually happening on the ground. So the less detailed and prescriptive that you can have those types of regulations, I do think it's better for actually both sides and the profession as a whole. This was a really fun exercise when Kathy brought it up. When we had our planning committee meetings and then you had the lawyers on the phone, we had so many ideas as to the themes of our presentations and all the legal issues we could bring up. We had everybody, lots of different perspectives, and we couldn't fit it all in, and it wasn't going to be as entertaining for the non-lawyers if we did an academic exercise. So hopefully this was fun for you. But in our hypo, or our presentation, if you notice, there was a host of things that we could have gone off on tangents with. First, there was the licensure issue, for sure, and the standard of care. And then, though, there was this nod to the difficulties in the health information exchange and how information should be flowing seamlessly. Part and parcel with that is I think from a privacy or security standpoint, is the technology and the exchange generally of information secure and private. That wasn't so much highlighted in our hypo, but something that comes up from time to time. Also mentioned on our hypo was, it's all about the money. I just need to keep working, and they're really incentivizing me from a financial perspective. In my world, I think stark and anti-kickback violations. So that's, even though we're in telehealth, and it's not just telehealth licensing regulations, it's everything else that has to be analyzed in an adjusted fashion when you're in a different service delivery model. I also, there was a mention of telepresenters. Was a telepresenter present? And we were certainly casting Carrie in a horrible light. So anything she answered, I think by the 20th question, we just assumed she was wrong. But the telepresenter is not a slam dunk, whether or not one was there or not. A lot of states have either required one in the past and in their recent iterations of their regulations have removed it because it seemed to be another barrier, another extra that telehealth providers had to comply with. However, in talking with some clinicians, they will tell me, for this type of encounter, a telehealth presenter really is helpful, and I could argue it should be required at all times. So it could be a factor to analyze to see if the standard of care for that particular encounter was met. Not necessarily it should be required by state regulation for all times, because again, state regulations, in my view, should be able to be fluid enough to adapt to all sorts of circumstances, but it was another element that can be critiqued when standards of care are critiqued. And then the acute care facility, the questions for Carrie related to, did you know where she was? Did you know how close the acute care facility was? Those are questions with a nod to a very common element in state regulatory regimens that require physicians to have an emergency plan. telehealth encounter, to have an emergency plan if things go bad, if the technology goes out, if that person is visibly having some sort of emergency episode. That emergency plan could mean all of that. And knowing your emergency resources in the area of where that patient is, arguably is something that the telehealth provider would need to prepare for. And again, this could be just mentioned in your state license regulations, have emergency plan, period. It could be more detailed, knowing where local ambulance providers are and more detailed requirements, or it could be something discussed in board documents. The point is just to be very educated and to keep up with it, since guidance documents and different developments on a state-by-state basis are seemingly at a good clip these days. I think that's all I had to say for my part.
So I'm not a clinician and I'm definitely not a lawyer, but from the technical aspect around this fictitious scenario, from the Quickie Mart standpoint, the strategy on what devices to have or not have, obviously it seemed that there was some poor planning around that. Making sure that you know what type of solutions you're going to put in these kiosks, what type of medicine you're actually going to perform in these kiosks or in the scenario. Obviously, there could be better strategy around how to properly plan these solutions, making sure that you have a digital stethoscope, making sure you have all these devices, but then also making sure that you have the proper way of cleaning these devices from one patient to another, or how do you certify that these devices are working from one day to the next. All that goes into your telehealth strategy. In regards to the recording aspect that was talked about earlier, obviously the legal folks can talk about that, but obviously that was not something that was done. From the interoperability standpoint, from health information exchanges, huge key in regards to not only linking your telehealth platform to your electronic medical record, but then also how do you get that data into your health information exchange, not only using your standard connections between vendors, but then also looking at how do you do this with open source like Fire or HL7 and that kind of stuff. Again, that's on my technical side. From where I work right now, we do a lot of stuff with the government, so looking at open standards is a huge plus. But making sure that you're properly looking at this, making sure that you're properly strategizing, how do you connect all these systems properly? Not only connection, but how do you make sure that the data is there and it's in a fashionable, quick sense of getting to that data is very key. So that's pretty much it.
I had a couple of other comments. One of the ones that you mentioned was the recording, and I don't want to get into that too much, but there's pluses and minuses to recording in the healthcare setting, whether it's telemedicine or in a physical setting, and there's also some concerns that you would have to get appropriate consents from the parties. And speaking of consents, and I think informed consent is very important in all healthcare settings, including telehealth. And one of the things that you could consider putting in your informed consent, at least for parents, is the importance of following up with the guidance given by the clinicians, because obviously in this scenario there were poor outcomes because there was a failure to follow up. So maybe putting that in, kind of alluding back to what Neil had mentioned from the Children's Hospital in Atlanta, the responsibility of parents in that particular scenario. Speaking to the physicians that are in the audience, you can't rely on the corporate negligence, if you will, as a real defense, as much as I tried to kind of allude to it here. You are licensed by the board, you're responsible for your own actions, and so you really need to make sure that if you're going into one of these situations with Quickie Pharmacy or whatever it might be, that they do have what you need to practice medicine, or you really shouldn't enter into that scenario, whether they pay great dollars or not.
All right, we're going to move forward. I am not sure if we got the technology in sync here, but we'll see what happens. We're going to, now that we've talked for 10 or 15 minutes, we're going to try to find out if we've changed your mind on any of these points. So we're going to ask the same questions again. I think we asked 5 before. I see 4 here. Oh, well. Anyway, and we hope that the information will be, the old and the new vote will be projected simultaneously, so here goes. Let's do question number 1. Should the board sanction the physician, Dr. Imreldum? A vote yes is she would be sanctioned. Ah, wonderful. Pre, post. So you've softened and been a little bit more sympathetic to her difficult situation, and I think that's reasonable. All right, let's move, let's see. We'll go to question 2. Quickie Pharmacy, did they have contributory negligence? A vote yes would be that they are contributory. And almost identical. So we haven't convinced you one way or the other. Very good. Next question. Was there a technology problem here that contributed to the bad outcome? A vote yes would be that there was a technology problem. Identical as far as I'm concerned. Okay, let's do the final question here about the parents. You gave her a 90% thumbs down before. Were the parents contributory? A vote yes, and you think that maybe they are a little bit more contributory. Okie doke, thank you very much. I think we have time to open up for some questions from the audience. All right, I'll read the first one. I'm not a provider. Is pneumonia a difficult diagnosis as a first encounter with many patients? Oh my, this is a really tough question, and yes, it can be difficult. In the hospital where I live, it gets really difficult. I think in the community, I imagine it's less so, but I would defer to Carrie, who's a frontline provider there.
Ironically, in pediatrics, the most common pneumonia that we see in the outpatient world is something called mycoplasma pneumonia, which is referred to as walking pneumonia, and it's an X-ray negative pneumonia. So yeah, and it's actually very, very common in pediatric outpatient setting, and sometimes these will progress into other bacterial pneumonia. So no, it's not that difficult, and ironically, I probably wouldn't have treated the patient differently. Except for I would have preferred that the patient have a strep test before I give them antibiotics for a sore throat.
I'll read the question and defer to legal counsel here. Has any medical board in matrix states ever disciplined a doctor for telemedicine services?
In Virginia, they have. I'm not sure about the other states.
I am not aware. Before this conference, I had reached out to our experts in our firm. They were not aware, but to echo what Joe had said, I think there have been things that have been settled outside of even a board hearing, but nothing formal.
Boy, I'll take the one that says, it appears she was undertrained in telemedicine before using it. Is this common realistic? It seems telemedicine training is very comprehensive these days. Absolutely incorrect. Very, very few providers have telemedicine training, and most of them are being forced to do telemedicine against their will. And training is minimal at best in most locations. And nowadays, you can go on Indeed.com and type in telehealth, physician telehealth, nurse practitioner telehealth PA, and see that there are hundreds and hundreds of jobs. They're usually remote jobs, and they just want to find a willing body to prescribe something, and they don't necessarily provide the training with it. And I'll speak towards one of our Maryland medical school programs that I think is definitely behind the times on training residents.
Let me take a question from the audience. Yes, sir.
Thank you. Great presentation. Judd Hollander from Jefferson. Very difficult thing that I wrestle with, and I'm curious how you see it. Many of the state regs, either through the medical associations or through legislative process, say that the standard of care is the same as an in-person standard of care. But yet in the medical legal world, right, that's not the standard of care. The standard of care is what a like provider would do in a like situation. And so these things conflict because there is no way that a telemedicine visit is exactly the same as an in-person visit, nor will it ever be, nor will a telemedicine provider do exactly the same as an in-person provider. Hence, these things don't make sense the way the laws are written. They conflict with each other. I think, in my view, it might actually be important that you get to the right action. If an x-ray is needed, order an x-ray, but it's not the same as an in-person visit, i.e. listen to the lungs, don't listen to the lungs. From a medical board perspective, you must wrestle with that or think about that. Can you care to comment on how that gets thought about?
Do you want legal counsel or medical answer?
So I guess maybe a combination. I mean, me as a physician, I'm just going to do what's right for the patient, and I'm not going to get caught. I kind of always think I got to go home and sleep at night, and I got to take care of the patient. But I also know I can never meet the statutory requirement ever with every telemedicine that I do, and I am a provider who does telemedicine.
So I had almost the exact question from a series of psychologists which wanted to expand their telehealth provider outreach, not in Maryland or any matrix state, but that was their exact question. And so as a regulatory attorney that works with providers, I very much need to partner and understand where the providers are coming from. What I typically will say in that situation is the standards and the professional judgment that you're exercising will be consistent in in-person or telehealth. But yes, when you are having a telehealth consult, you have to consider and exercise your judgment on factors that are not present in the in-person. You have to think about, and this was, again, psychologists, but I've had a question from primary care physicians as well, is this person, particularly if they're undergoing some mental health episodes, if they are in a very excitable state, I actually posed this question to them, if they're in a very excitable state and they're having a telehealth consult, what would you do then? And they said, well, I think I could treat them, or I would probably be able to diagnose them, but for that patient's safety and the overall wellness of that particular patient, I'd want to see them in person. Again, a hypothetical. But it's still that same analysis and the same education and professional judgment that's applied, but they're just varied factors that telehealth does present. Because as lawyers, and I think as clinicians, and Neil can speak to this, and Carrie, the desired gold standard, the desired standard is the standards are the same. You don't want to have a different standard in telehealth as compared to in person, but acknowledging it may be a different analysis in telehealth.
I'm not even sure where to begin here. I give a lecture once a year to our students about you can learn a lot just by looking. And I begin that discussion with the parts of making a diagnosis. Number one, you take a history. 2, you do an exam. 3, you order diagnostic studies. You make most of your diagnoses, way in the 90%, by the history. Talking. Talking is probably the most important thing. You don't even know where to put your beginning the exam if you don't know where they're having a problem. So would you listen to their heart when they said they had a pain in their leg? You got to get history. History is by far and away the most important. Then the physical has some points that are a bit problematic. And I shouldn't say this in public, but some people question the value of auscultation, particularly in certain settings. It is not as diagnostic as you'd like it to be. So if I had of the examination, however, looking, you can make many of your diagnoses just by looking. Of our senses, we don't taste people too much, although they did in the past for cystic fibrosis. We don't smell them too much, although you might. Your sense of looking is probably one of the most important senses you use. And in fact, a lot of what we do in clinical medicine, which is look into the stomach with a scope, look in the ears with a scope, look in the throat with a scope, it's all looking, but using a gizmo to get you there. If I could do nothing but talk to a patient and look, you get the vast majority of your diagnoses right there. Then, of course, we confirm or sometimes deny by the physical. So you're right, it's not an absolute parallel. It's not exactly the same. But if I could train a student to talk and look, and walk away and try and make their diagnosis. I think that'd be a lot better than just coming in, putting your stethoscope somewhere, and trying to make a diagnosis. So the exam is important, but take a look at the patients.
I guess I would say that the standards are relatively similar, but you can't take away from the fact that there are technical issues that you're dealing with when you're dealing with a telemedicine consult. And there really, as Joe pointed out in the previous presentation, there isn't a lot of case law, but at least from my experience dealing with medical boards, they are going to look to make sure that you took, reasonable measures to ensure that there was, proper equipment there for you, that it was working, and so those are things that do need to be considered as part of the evaluation of whether the treatment was appropriate and reasonable under the circumstances.
I'm going to echo what Neil said, and I used to teach as well, and I would teach my students that 95% of their diagnosis is made on their history, and then the other 5% is confirmatory with the physical exam and diagnostic testing. I actually feel like I'm a better healthcare provider when I do telemedicine than I am in person, because I frequently examine the patient and talk to them at the same time when I'm seeing them in person. I'm looking in their ear, so does your throat hurt? And I'm doing double duty when I'm seeing them in person. When I'm doing telehealth, I'm very, very attuned to my history taking because I know I lack that physical component. So I feel sometimes that I'm a little more effective in telehealth than I am in person. And I also get to see a lot more of them in an alternate environment. Many of the patients I see are not in a traditional exam room, and so they act and walk and sit differently than they do on an exam table. I also have the advantage of being able to turn my audio and video off on my end, and I can still observe the patient and listen to them while they don't know I am, and I catch a whole host of things that way, which is really a whole other story. But yeah, the history is such a critical part of what we do. So I never like to think of it as less of. I always tell people it's a different type of exam. It's not less, it's just different.
I'm going to read the top question, which has kind of been addressed a little bit, but here we go. It appears she, Dr. Imreldum, was undertrained in telemedicine before using it. Is this common, realistic? It seems telemedicine training is very comprehensive these days. First off, Dr. Imreldum was an actor. But the truth is, University of Maryland, I can speak for, there's School of Medicine, very, very little training in telemedicine. It took us several years to get the dean to agree to allow us a 3-hour seminar, which we started doing about 3 or 4 years ago, I guess. And I do a 1-year sort of lab with them when they get some hands-on experience. It's been very hard. The difficulty is medical school is 4 years long, and the dean has it jam-packed full of things. And to pry a little bit of time away from it is very difficult, incredibly difficult. Now, we have a psychiatry program at the University of Maryland where they actually teach their residents and fellows and they do telehealth in that program, but it doesn't happen a whole lot. So I think the training, at least speaking for Maryland again, is way, way behind where it should be.
And along that line, I graduated from Georgetown 29 years ago when I was a very young child graduate. Telehealth didn't exist in the realm of everyday life. And I'm actually the providers that people are looking to recruit for telehealth. They're looking for the soon-to-be retired, quasi-retired, want-to-go part-time providers that have experience. And we are the least prepared to be doing this, yet the most valuable to these companies wanting to do telehealth. They want experienced providers to do that. So it's kind of an odd world existence.
Okay, I think I'm told that maybe we should wrap it up unless there's another question or two from the floor, and I don't see anybody standing. So I want to thank you all very much for your attention. The questions were great, and thank you.